Welcome to this infographic-based educational activity in which Professor Alan Irvine from Trinity College Dublin and Children's Health Ireland discusses strategies to improve the diagnosis and treatment of atopic dermatitis. The following podcast is part of a certified educational activity titled Addressing the Global Burden of Atopic Dermatitis, a Roadmap to Improving Diagnosis, Treatment, and Complete Patient Care. Access the entire activity and complete the post-test at peerview.com/GVC860. Downloadable infographics are also available.
Today we're going to talk about atopic dermatitis and provide a few tips to diagnosis, to treatment, and take a holistic view of patient care. Atopic dermatitis often is also called atopic eczema or eczema. It's a chronic inflammatory condition. It's the commonest inflammatory skin disease in developed societies anywhere in the world, and increasingly so in developing societies as well. It's distressing, it's itchy, it's uncomfortable. It has a big impact on quality of life. Most patients with atopic dermatitis will get manifestations before the age of 2, perhaps up to 80% before the age of 6 years. The condition doesn't have a regular standard trajectory. That means people can lose atopic dermatitis and regain it again. It can come and go, or it can be persistent and severe, and we'll explore that a little later on in this learning opportunity. We see prevalences of perhaps 10% up to 20% in children and somewhere between 3 and 10% in adults. Increasingly, we're seeing onset in adults over 60, and that's a relatively newly recognised cohort of patients. Again, it seems to tie very well with urbanisation and more developed societies. If we look at the prevalence and how it's been shifting and which societies it is more developed in, you'll see in Northern European countries it's extremely high prevalence rate. More than 20% of children up to 13 to 14 years will have atopic dermatitis. Very common in New Zealand and in Japan. In other countries it's been lower incidence, but it's increasing over the last 2 to 3 decades. It's a challenging condition or disease to live with. It's painful, it's itchy, there's a huge loss of sleep, which leads to chronic fatigue, underperformance in work, underperformance in school. There's often other atopic comorbidities as well. These include asthma, which about 50% of patients will have, rhinitis, again, maybe up to 70% of patients, food allergies, perhaps in 20 to 30% of children. Mental health issues are a significant burden as well, and we're learning more and more about these. Anxiety and depression are commonly reported. In younger children, attention deficit hyperactivity disorder is reported very commonly. The link between that and sleep disorder is not fully elucidated. It may just be a manifestation of chronic loss of sleep, which is very debilitating over time. There's a strong stigmatization with skin disease, and people often are embarrassed or cover up their skin, avoid social situations, don't swim, don't play sports, wear different clothing because of their eczema. Cumulatively, it can create a lot of misery. There are some significant impacts when it comes to college and career. Absenteeism is certainly an issue, losing time off work, off school, off college, and presenteeism as well, where people are present in work but they're extremely tired and not as functionally active and as productive as they would wish to be, can become a significant issue in people's lives as well. People's intimate and sexual life can be affected, again, through self-consciousness of their skin, through pain in their skin. Genital dermatitis can be a significant problem as well. We don't have a lot of data on family life, but we do know that the parents of a child with eczema experience extreme stress, and it's an extraordinarily challenging condition to live with. Just to feed into the caregiver impact, caregivers often lose sleep too. If the child's not sleeping, the parents, one or both, aren't sleeping either, and that feeds into a kind of amplifying effect. So the parents are also absent from work or present but very tired, and cumulatively this again adds to the burden of the condition. I'm going to pivot a little now and talk about the pathophysiology and what's the cause of atopic dermatitis. It's easiest to think of it as a trilogy, really, where we have a skin barrier problem, an immune dysregulation, and a disordered microbiome. And all of these are forced in a certain direction by environmental exposures. The strongest genetic risk factor is filaggrin mutations, and the strongest immune polarization is type 2 polarization of the skin. You also see type 22 and type 17 activation, but type 2 activation is by far the strongest driver in the immune side. This summarises the features from an acute lesion where clinically unaffected skin still has significant pro-inflammatory characteristics and skin barrier disorder and microbiome disorder, even though it looks normal. In a patient with atopic dermatitis, none of their skin really is truly normal. As we progress through from acute to more chronic lesions, we see thickening of the skin, lichenification, and a recruitment of additional arms of the immune system. Just to look now at type 2 cytokine signaling in atopic dermatitis, what are the molecular pathways that drive this condition? The key cytokines, the absolutely most important ones, are IL-4 and IL-13, and they signal through these receptors called Janus kinase receptors, which face inwards and outwards of the cell like the Greek god Janus. So JAK1 and JAK2 kinases are the key kinases for signal transduction of interleukin-4 and interleukin-13, and they then signal on through the STAT pathway, mostly STAT6. IL-31 also signals through JAK1 kinase, and IL-31 is a particular cytokine that's very relevant for itch. When it comes to microbiome disorders in atopic dermatitis, we must remember that when we're born, we rapidly acquire the microbiome that lives with us for all of our lives. We have more cells on and in our body that are microbial cells than we have our own native cells. So we're really technically holobionts. We live in synergy with our microbiome in our gut, in our skin, in our lungs, and on all of the mucosal surfaces. But what we see and what we're learning is that in infant life, the microbiome and the immune system crosstalk, and essentially the microbiome trains the immune system. So you need a healthy microbiome to have a healthy immune system in the skin as we go from the sterile environment, being in the uterus, into the wide world outside. The most important microbial entity for atopic dermatitis is Staphylococcus aureus, and this is a very long and well-known association. Staphylococcus aureus has evolved for human skin in a really precise way, and it has numerous mechanisms that allow it to glue to our skin, adhesion molecules. It has a lot of pro-inflammatory molecules that drives inflammation in the skin and disrupts the barrier. And then it has specific toxins that just dissolve our skin barrier, proteases and toxins. So this is an organism that really is very destructive to skin. And when it proliferates, it's a key driver of atopic dermatitis. And many people with atopic dermatitis struggle to clear Staphylococcus aureus. We're going to look a little now at the clinical manifestations of atopic dermatitis. So it's a very heterogeneous condition. That means it can look very different between races, between ages. So most of us will know that children often get atopic dermatitis on their face. The cheek is often the first manifestation, but it can be quite widespread. And you can see in the top left panel, a baby actually scratching itself because it's so itchy. In later childhood, it can affect flexural areas in front of the arms and behind the knees in the fossae. As you get a little older, it can become more thickened and more lichenified. And we see more lichenification in Asian skin and in African skin than we do in European skin. If we look at the distribution, we can see that it moves around from a more extensor surface in a baby to a flexural surface in a young child, and then perhaps a more generalized pattern in adulthood. And of course, we can get different patterns to that. Some people just have head and neck manifestations of it. The diagnosis of atopic dermatitis is usually clinically pretty obvious. There are formal diagnostic criteria, which I'll review shortly, but it's always worth asking about family histories. Are there other siblings affected or parents affected? Is there a background history of atopic diseases such as asthma, allergic rhinitis, or food allergy? If we look at the kind of common diagnostic features, most doctors can diagnose this pretty easily, but in the absence of itch, it's very difficult to make a diagnosis of atopic dermatitis. So if you've got an itch and a rash that's relapsing and remitting, and it appears to have a typical pattern, you can get a little bit more confident that you're definitely dealing with atopic dermatitis. Then you might look for the age of onset, personal and family history of atopy. If you know there's IgE activity, that's helpful. If the skin is extremely dry, that can also help as well. How do we assess severity? So in real life, in practice, we'll assess severity more by the impact that the condition has on the individual, whether it's a child or an adult. You can use complex scoring tools, but often just normal human communication and saying, how much sleep is being lost by this, how extensive is the condition, how much treatment is being required to control the condition. If it's a child, how many days are they losing from school? If it's an adult, are they losing time from work? Have they got persistent sleep disturbances? And so on. So there's real life scenarios, and then there are tools that are used in clinical trials, such as the EASY and the SCORAD. You'll rarely use these in clinical practice outside of a clinical trial. There are simple tools that you can use as well, just a visual IgA score, which is a fairly simple score, and you can rate patients from 0 up to 4 depending on how severe they are. Let's look at some examples of mild eczema. You won't see oozing or crusting in mild eczema. The skin will be a little bit thickened or a little bit swollen. It'll be red, which can be difficult to appreciate if we're looking at, for example, black skin, but you will see the discoloration. You'll often see some excoriations as well. If we look at moderate eczema, we'll see more significant manifestations. There might be some oozing and crusting. It might be more extensive. The skin could be dull and red or bright and red. If we look at severe eczema, it'll become a good bit more obvious. You might see some oozing and crusting and a more widespread rash. Differential diagnosis of eczema, as I said earlier, it's really generally very obvious that somebody has got atopic dermatitis or eczema, but occasionally there are curveballs and there occasionally are mimickers that are a little bit difficult to distinguish. Scabies is one. In a young child, that can be difficult. Usually there'll be a contact with somebody who has scabies, a family member perhaps, or someone in school or a cousin or someone in daycare that may have transmitted it. As we go down other lists, when we get into really rare conditions, immunodeficiencies, Netherton syndrome and so on, they're usually pretty obvious. The distinction between seborrheic dermatitis and atopic dermatitis can be difficult, because kids with atopic dermatitis often present with a seborrheic pattern, cradle cap, itchy scalp and so on. But normally in infants, it's pretty straightforward. As we move into older kids, impetigo can sometimes look a little bit like eczema, but it should just be an acute onset. Occasionally, it's difficult to tell the distinction between psoriasis and eczema. And in rare cases, some children and adolescents will actually have manifestations of both psoriasis and eczema. It's certainly unusual, but we do see it. As we get into the adult age, psoriasis again can be a difficult differential, particularly on hands and feet. It can be really tough to tell them apart. Fungal infections can mimic eczema and allergic contact eczema, but normally there are some clues as to the distribution. I'm going to show a fairly simple model of the atopic march. It tends to behave in a little more complex way than this, in that you don't have a simple march through all of these. But eczema is often the first manifestation of atopic multimorbidity, and that's probably the best way to consider atopic dermatitis comorbidities, in that you can at any point have a high risk of asthma, allergic rhinitis, food allergies, and that they can peak at certain times in life, but any one individual may work along this pathway in their own way. What you see presented here is a kind of aggregate view, but actually any one individual may well present with these in a different sequence or not at all. So it's quite possible to have asthma and atopic dermatitis and never develop rhinitis or food allergies. So people have a selective a la carte menu of these comorbidities. When we consider how food allergy and atopic dermatitis interact, in nearly all cases, food allergy is an additional problem. It's very rare for food allergy to be the primary driver of atopic dermatitis. That's seen only very rarely in practice and normally relates to milk allergy, but it's a rare phenomenon. What's much commoner is kids who get atopic dermatitis have a hugely increased risk of food allergy, and that's because their skin barrier is first of all weakened and secondly very immunologically activated. So this is a perfect storm where you get exposure to allergens, food protein allergens particularly, specifically milk, egg and peanut, egg being the commonest. Instead of introducing these allergens through the oral route where the gut will drive tolerance so you can continue to eat, if you get exposed to these allergens through the skin immune system, which is completely different from the gut immune system, will drive allergies. And if you have a very activated and broken skin barrier, much more likely to develop allergic sensitization and a memory that you will react to these allergens. The evidence in this direction in humans, apart from all of the animal models which push things that way, there's some really nice clinical trial evidence called the LEAP study. And this is essentially looking at high-risk infants, those who've already had some high risk of peanut allergy because they'd had egg allergy or family histories and so on. Early introduction of peanut orally greatly reduced the risk of becoming peanut allergic in this group. So it's an important marker for the development of tolerance by eating foods early. And this is something that has changed clinical practice since it was first published over 4 years ago. Now we encourage early adoption of all foods in kids who are not already allergic to them. I'm just going to summarize some of the additional comorbidities of atopic dermatitis. Ichthyosis vulgaris is a common dry skin condition. It's driven by filaggrin mutations and it's intimately associated with atopic dermatitis. Atopic eye disease is a real problem for a subset of patients. Keratoconjunctivitis, keratoconus, and significant problems with corneal distortion, and a small number of people who will need corneal surgery and specific treatment for that. The relationship between atopic dermatitis and the metabolic syndrome and obesity is really not formally worked out, and neither is the relationship with cardiovascular disease as well. Certainly, there's increasing evidence around mental health issues such as depression, anxiety, and suicidal ideation, but not yet, as we've seen, completed suicide. And ADHD, attention deficit hyperactivity disorders, an additional complication in many patients. Infectious complications are common, bacterial, fungal, and viral. So the commonest bacterial infection is certainly Staphylococcus aureus. Up to 80 to 90% of patients are carriers, and when Staph aureus becomes a dominant microbial pathogen, it normally heralds a flare in eczema. Patients with eczema are at high risk for eczema herpeticum, that's the herpes simplex virus, the cold sore virus, which spreads rapidly on atopic dermatitis skin and causes significant problems. Another common viral infection is molluscum contagiosum, which can be a real nuisance and require treatment. Fungal infections are common. Malassezia infections are common. The endotype, or the specific type of atopic dermatitis that any one patient might have, will be driven by their genetics, by their gender, by their ethnic background, all of which provide a template. Everything they've been exposed to, pollutants, irritants, what way they've been washed, what moisturizers they've been applied, all of these environmental factors. And then we look on the other side, we'll see their sensitization profile, what they're allergic to, how their immune profile is skewed, how their skin barrier operates, what age they were when the atopic dermatitis first manifests, how severe it is, do they have atopic multimorbidities as well, and how their disease progresses over the long term. And these are all individual to each patient that you're going to treat. So it's worth thinking where this patient is on their pathway, how severe they are, how long they've had the condition, and so on. The goals of treatment are quite obviously to reduce symptoms, which is itch predominantly, to try and prevent exacerbations. You really want to give your patient or their parents, if it's a child, the confidence that you've got good long-term control that you can really manage for a long time. And normally it requires a few different approaches, careful management of the skin barrier, good moisturization, and then appropriate formal treatment regimens. The simpler the regimen is, the more likely it is to work, because people are busy, parents are busy. It's difficult to spend lots of time doing really complex regimens. The simplest ones will always work the best. If we look at treatment guidelines, they're very similar really globally. There are country-specific guidelines in the UK and the United States, in South Africa and Taiwan. Those guidelines tend to have quite far reach, and there are some European task force guidelines as well. The atopic dermatitis yardstick is quite widely used and adopted, going through basic management of non-lesional skin, mild atopic dermatitis, moderate, and then severe. The basic management pretty much stays through all of those, good skin care and trigger avoidance and so on. As we get into moderate atopic dermatitis, we'll introduce topical corticosteroids and perhaps topical calcineurin inhibitors to affected areas, and often in a step-down approach after initially treating for a few weeks to gain control, then stepping back to perhaps alternate day use and then weekend use for maintenance. And in severe eczema, there'll be consideration of more significant measures, including systemic drug therapies or phototherapy. These are the consensus European guidelines, which again are relatively similar, bringing in phototherapy here with moderate atopic dermatitis. The European guidelines define moderate atopic dermatitis severity based on SCORAD. It's a score that was developed in Europe. But in real life, outside of clinical trials, the SCORAD would not be widely applied in clinical practice. People don't typically do these scores. They rely on their experience and they rely on patient stories, how severely affected is their life. There are fewer systemic therapies licensed for children now, and for children often a few days in hospital if it's very severe helps if that's available to you in your healthcare system. Not every healthcare system has that. Also systemic immunosuppression might be needed. That's a rare number of patients that need that. Truthfully, most patients will form lower down the pyramid in the mild or the moderate eczema categories, and they will be managed as we've discussed earlier. One thing that's worthwhile considering is just how to limit anything that exacerbates the eczema. Certainly if anybody's got any known allergies, contact allergies or food allergies or allergies to aeroallergens such as dogs or cats, horses, cut grass, they should be avoided as much as possible. It's good to avoid sodium lauryl sulfate or foamy detergents. They dissolve the skin barrier and make things much worse. Really dry environments or low humidity environments are best avoided. They make things more difficult. I'm going to talk a little bit about controlling pruritus. Antihistamines are widely used, but truthfully, if you're using a lot of antihistamines, it really means you're failing to control the primary problem with atopic dermatitis, which is inflammation in the skin. There's not a great deal of evidence to suggest that antihistamines, more than in very short-term settings, are of any use in atopic dermatitis. They shouldn't be part of the regimen for more than just intermittent short-term symptomatic relief. Topical corticosteroids do improve pruritus. Whichever country you practice in, it's worth understanding your topical corticosteroid strengths, which products are available to your patients, which products are affordable, which products come in creams, which come in ointment forms, and learning those and becoming familiar with those, making sure you know the correct volumes, the correct strengths, and the correct durations of treatment. The adverse effects of topical corticosteroids are well rehearsed, and many people are familiar with them to the point of being overly intimidated about using them. Steroid phobia or steroid reluctance is a very common phenomenon, and it often gets in the way of people using topical corticosteroids, often to their detriment, and often too few are used. So it's worth using and learning scales like how many fingertip units your patient will require, whether that's a child or an adult you're treating, for how long, usually for a few weeks, and then stepping down, and using the minimum potency. If you do that, you will minimize and generally eliminate adverse effects of topical corticosteroids. It's possible to thin the skin, particularly sensitive sites around the eyes, in the skin flexures where the skin is already thin, genital skin. You should have used low-potency corticosteroids on these sites of particular sensitivity. Other sites, like the scalp, the palms, and the soles, can take more potent corticosteroids with no significant problems. If you see a patient who's been using steroids for a very long time and clearly does have some topical corticosteroid adverse effects, that's a time to think about how to remove or lessen their dependence on topical corticosteroids, either by using alternative topical treatments, including calcineurin inhibitors, or by advancing to phototherapy or perhaps getting specialist help for systemic therapy. Topical calcineurin inhibitors do not cause skin thinning. The currently approved ones are tacrolimus and pimecrolimus cream. Tacrolimus is an ointment and pimecrolimus is a cream. Tacrolimus is generally more potent than pimecrolimus. There have been some concerns about a link to lymphoma, but they have not been substantiated in long-term studies as yet, and they're widely considered to be safe. They're probably best not used in really activated, active skin. You're best treating that with topical corticosteroids first. If you put them on very inflamed skin, the likelihood is you'll get an adverse site reaction, a burning or a tingling or a sense of discomfort. That can put patients off long-term compliance with their treatment. If we look at Crisaborole, this has been an approved treatment based on some of these trials published 4 years ago. It's a phosphodiesterase 4 inhibitor, and that's a pathway that's been around and of interest in atopic dermatitis for more than 3 decades. But this is the first time anyone has developed a product based on that. It's generally used in mild or sometimes moderate atopic dermatitis, usually in conjunction with topical corticosteroids or as a steroid sparing or steroid reducing move. There are currently further ongoing trials versus an active comparator, the results of which have not read out yet. Infection, when it's present, needs to be treated. Colonization does not. So Staph aureus is a common colonizer in atopic dermatitis, frequently present, but only if you see actual signs of bacterial superinfection. That could include weeping, crusting, and vesicles, or you might see punched out erosions that look like shotgun wounds, and that can be a sign of eczema herpeticum. These all need to be treated with topical antimicrobials, oral antibiotics, or oral antivirals, depending on what the infection shows. Bleach baths are widely used, but the evidence base is thin and not convincing that it really makes a difference. Despite that, it's a staple of management. The benefit of sunlight and of light in atopic dermatitis has been known for some years. Certainly, heliotherapy or exposure to natural sunlight is possibly best of all, and that's probably due to more environmental factors than simply just the UV. So when people from Northern Europe have holidays in Southern Europe, often their skin gets better. But of course, they're on holiday. They're getting more than just phototherapy. They're getting rest, relaxation, difference in humidity, more outdoor life, less indoor heating. There are many different moving factors in these patients. The most common medically prescribed phototherapy will be narrowband UVB, which is done in specialized centers. This works for some patients. Some patients find the heat quite irritating and they don't find it helpful. It works better for people with more pigmented skin. Fitzpatrick type skin 4 and above, it's often very useful for. It's not particularly suitable for infants and young children for obvious reasons. They can't really stay still in the light box under the age of about 6 or 7. And there's a concern about cumulative exposure to sunlight and potential carcinogenesis in very young children. When we look at systemic treatment options, there are some legacy immunomodulatory drugs that have been repurposed, things like methotrexate, which have been moved from cancer therapies and used at low doses for psoriasis, for arthritis, and increasingly for eczema, and they've been used in children and they've been used in adults. Other drugs come from the transplant population experience, and they include azathioprine, cyclosporin, mycophenolate. These are drugs which all can confer some benefit for atopic dermatitis, but there are very few properly conducted randomized clinical trials for these conditions. More recently, there's been a real explosion of interest in developing drugs specifically for atopic dermatitis. Dupilumab inhibits the interleukin-4 receptor, through which both interleukin-4 and interleukin-13 signal. By blocking that receptor, you can get a very substantial improvement in atopic dermatitis. And this is a drug which has been approved now in the US, in Europe, Japan, and elsewhere for systemic treatment. It's a biologic that's injected every 2 weeks. These are just some of the pivotal clinical trials for dupilumab therapy versus placebo. What we see is the investigators' global response at week 16 and the EASI-75 improvement at week 16. So somewhere around 50 or 60% of people are getting EASI-75 improvements at week 16. We're looking at the 12 to 17-year-old data, which is comparable to, if not exactly identical to, the adult data. Here we get EASI-75s in the low 40%, so a little bit lower in this age group, and we're not sure if that's a dosing effect or if there's a difference in the condition in adolescents, or if this particular group just happened to be more severe and had slightly less positive outcomes. But it's still very good for many patients who need it. Who is a candidate for systemic therapy? Well, do they have moderate or severe eczema, by whatever way you define it? Have they tried lots of topical therapies and not had a response? Are they unable to continue with the plan? So it might be one thing doing really well with creams and ointments, but it might be that that's an impossible burden for somebody to bear. And there's no point in pretending that they're going to be able to continue with that if they can't. And you need to have a realistic conversation there about where you might go with alternative treatments. There's about 70 molecules currently in clinical trials from phase 1 to phase 3 for atopic dermatitis. And these include other biologics that target the type 2 cytokines, including IL-31, IL-13, which are in phase 3 testing. There's a proliferation of JAK inhibitors, some of which have completed phase 3 trials. Upadacitinib, baricitinib, abrocitinib are all in advanced clinical trials. There are topical JAK inhibitors, which are in clinical trials as well. So just to double back on good communication of a treatment plan. A treatment plan will work if it's really simple. It'll work if it doesn't impose too much on patients and caregivers. It'll work if it's well communicated, and often it's best to have both a physician and a nurse reinforce the treatment plan to get really excellent outcomes. The more comfortable people are with their plan, the better the outcomes are likely to be. And written down instructions, videos, ancillary materials, many of which are available for free on the internet, will really drive good results, especially focusing, if it's a topical regimen, on the fingertip unit and appropriate treatments. It's amazing how many people are afraid of using the appropriate volumes or the appropriate duration of treatment. And it's also amazing how many pharmacists, for example, will scare people off in treatment regimens. So the more confident that people are when they leave your office, the more likely they are to get good results when you see them back in a few weeks' time to see how they've gotten on. There are many dermatology patient organizations who are trying to drive better patient outcomes and drive better collaborations, remove obstacles, and improve clinical management. These are worth engaging online to get better informed patients. The more informed patients and families are, the better their outcomes will be, the happier they will be, and the easier your practice will be.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/GVC860. This activity is supported by an educational grant from Pfizer.